Welcome to Conversations in Physical Therapy Research. Throughout this series, we'll be joined by physical therapy researchers and other voices in the PT community to talk about the role of research and how it helps shape the evidence base that supports the profession.
Today, we are honored to speak with Steph, a physical therapist researcher at The Ohio State University and leading expert in orthopedics and sports medicine, whose research is advancing how clinicians understand and treat musculoskeletal conditions. Steph's work focuses on pragmatic clinical trials, technology-driven assessments, and optimizing exercise dosing, all with the goal of improving patient outcomes in the real world. Steph, thank you so much for joining us today.
Thanks for having me.
So let's start off with your story. Could you tell us a little bit about your background and what excites you the most about your work?
Sure. I think I came to the field of physical therapy like a lot of people. I played a lot of sports. I had a lot of injuries. I had a brother who sustained a pretty traumatic knee injury and watched his experience in rehabilitation. And so when I went to PT school, all of that was on my mind. And so orthopedics and sports medicine was the natural course for me. And through a lot of conversations with professors and experience in the field, I kind of found myself stumbling towards the research line. And then, off I went in pursuit of a PhD. And I guess the rest is a little bit of history.
How has your perspective on the field and research evolved since you first started?
Oh my goodness. Well, to say I really didn't know much of anything when I first started, I think is a little bit of an understatement. I didn't even really understand fully the breadth and depth of physical therapy research. Again, coming from that sports and orthopedic space, I really had only been exposed to that particular area of focus. And as I moved through my PhD training and moved on to my postdoc and then joined the faculty here at OSU, I think I really, was able to open my eyes to all the great work that's going on. Such mechanistic works, translational work, and implementation science. I think PT research really touches all of those particular areas, and it's given me a much broader perspective on the type of impact we can have on human health.
I love it. And your research really puts a spotlight on pragmatic clinical trials. And for those of us who aren't researchers like myself, can you break down what a pragmatic clinical trial is and why it's so useful for finding real-world solutions?
Sure. So a pragmatic clinical trial is pretty much like it sounds. It's practical, it's pragmatic, it's meant to give us a sense of the clinical phenomenon or the mechanism of effect as it would occur in the real world, in a clinic down the street, in an office building, on the field, and elsewhere. So it's really meant to be, like I said, a study of that clinical phenomenon or that mechanism effect, but in the messiness of daily life. And as someone who trained clinical trials in a laboratory setting, it was definitely a bit of a shift for me. But I think most clinicians, at least the ones I work with here at OSU, they really appreciate those that are pragmatic because it respects all of the dynamics of the clinical space, the time constraints, the complexity of the individual, the resources or lack thereof of resources. And when something has an effect in a pragmatic clinical trial, then the translation to clinic feels so much closer to home.
And what are some common misconceptions about pragmatic trials that you've had to address?
Okay, so because pragmatic trials are done in environments much closer to the real world or the real world themselves, they're often viewed as less stringent, less rigorous, and if there isn't an effect, then part of the problem is, or the questions about that process are, why didn't you do it in a laboratory first? Is it the treatment that's the problem, or is it the dynamics and complexities of the real world? It is hard to untangle that. Typically a pragmatic trial comes to be after there have been some more standardized, rigorous, protocolized assessments done in a more refined, a sort of sterile setting first, so that when you get to the pragmatic trial, you aren't worried about those potential issues.
And then Let's talk about some of like the influences on these trials. Can you kind of break down the patient and clinician perspectives on these trials?
Sure. So, I think from the patient's point of view, at least this is what we've heard from the patients that we've engaged with. They want something that feels ready to deliver or ready to come into their hands, in the next few months. And I think we've all heard the statistics that talk about or point out the many years, right? 15, 17, maybe 20 years from which research done in a laboratory setting come to be in a clinical setting. And so for that way, patients feel like this is much closer to something that I'm going to be able to have in my hands tomorrow, that's going to affect my rehab tomorrow or affect, someone else's rehab in the coming, weeks and months. From a clinical perspective, our work is so patient facing, and we have such good collaborations with our full-time clinicians. The things they say to us as researchers are, again, give me something that I can take with me to the clinic on Monday morning or on Tuesday morning. So they're also looking for an answer, a practical answer, and one that can be integrated with not a lot of intermediate steps. I think what we often do in the research world is we have a pristine environment. There are steps in sort of locked, ordered fashion. We then hand it over to clinicians, and they think like, what were you thinking? None of this is going to apply in the clinic. And so most of our responsibility is to make sure we engage patients and engage clinicians early in the process, so that when we design the study, we have something that we think might actually work and that they might actually use.
And Steph, I know that you work with large teams on these trials. What's that experience like?
Incredible. It's great working with a ton of other PTs, but it certainly enhances the scope of the work we can do, the perspectives we have on the work, and also so many of the health conditions that I work with in orthopedics and sports medicine necessitate cross-disciplinary or multidisciplinary collaborations. So, some of the individuals I work with are primary care physicians, surgeons, mechanical engineers, biomechanists, other biomechanists like myself, athletic trainers, sometimes physician's assistants, exercise scientists, exercise physiologists. I think the list goes on. And depending on what aspects and what human conditions you are focused on and where in the research, sort of line you're working, whether it's closer to the bench or more translation or more pragmatic, like we were talking about, different disciplines are going to come in and out of that team. And so I've always really enjoyed it. I like having a lot of big brains working on big problems. And so that's always been a fun aspect of the work that we do here.
And it sounds like you have just quite the team. And now I kind of want to talk about the other side of the team, which is some of the technology that you're utilizing. Sure. And I understand that you utilize motion capture in the clinical assessments. What does that entail, and why is this approach valuable?
Yes. So, I think if we were dare to go to the policy and reimbursement side first, we really need to be able to document therapeutic effect. It comes down to the value of the practice we provide. And so if we can't show with great precision that the work that we're doing, the education we provide, the interventions we provide are creating a lasting effect and something that brings people closer to their therapeutic goals, then why should they reimburse us? I guess is the rhetorical question to ask. So technology really helps us put numbers to the things that we've been trained to do. So a lot of movement assessment, when I first came up in physical therapy, was done strictly with our eyes. We are really good at observing movement, but we are certainly not as good as some of the advanced technology provides to us today. So motion analysis, 3D motion analysis, infrared cameras, markerless motion technology, accelerometry, inertial measurement units, all of these devices help us put numbers to human movement. And the exciting thing that's happening now is where we used to be constrained to the lab. And I don't know if you've ever seen those lab setups where there's cameras all around and we spend a lot of time putting markers on people. All of that technology is really evolving quite fast, and we're starting to be able to push that into the real world. And that, I think, is really beneficial because that's where people are doing most of their activities, right? And we can study them a little bit in the clinic, but if we can give them tools and technology to measure how they're moving and what they're experiencing in the real world, that just enriches our understanding of that clinical problem. And so with better data, we have better answers. We can develop better answers and solutions.
Absolutely. Technology is really emerging in the field, and I love seeing how we're using technology to enhance the patient outcomes. It's truly
Yes.
incredible. So, kind of moving on, I want to talk a little bit about the exercise dosing and patient care. And more specifically, what practical strategies do you recommend to optimize exercise and activity dosing for musculoskeletal conditions?
Yes, this is a hot topic with the students in my lab, the students we teach in the curriculum. And there's been a lot of conversation, I think, in the literature and in social media about the issues related to a term called underdosing, which is essentially capturing the idea that we might be providing the right treatment at the right time, but it just not enough, or not in the right in the right dosage. And so we're talking about like technology allowing us to measure change. It also can help us measure how much we're doing for the participant. And in terms of clinical scales or clinical tests that we can use to help ensure that we're providing the right dosage, that's a little bit different, but it goes back to some of the things that have been shown to be helpful in evaluating dosage before. So one particular scale is the ratings of perceived exertion, where the person is actually telling you how hard they feel like they're working. That crosses physical therapy settings, not just orthopedics and sports medicine. That is absolutely a useful tool if you're trying to tack somebody's cardiovascular system while they're walking or running or exercising on the treadmill, and the higher numbers on that scale mean higher work, and they're telling you they're a 6 or a 7 or an 8, which is a relatively low number on that scale. Then you can make a quick adjustment to how intense the exercise is. That's one that would have been classically used for decades. Another measure that we use in orthopedics and sports medicine is something called the soreness rules. This has come to light from a lot of tendinopathy work. Essentially, the idea is, exercise can be uncomfortable and you should expect some degree of discomfort and pain. But it's really the change in pain and how quickly one recovers from that pain experience that tells us a little bit about dosage. So in tendinopathy, again, we look to see, is the change significant, or is the change really severe? Are you going from a 2 out of 10 pain to a 9 out of 10 pain? And then the next day you're still at an 8 out of 10 pain? That would tell us we way overdid it. We did way too much. But if you're providing strengthening, routine, again, for somebody with tendinopathy, and they're consistently at a 2 day in and day out, and the loads are a little light, that's the time maybe to turn the dial on the volume or the resistance, or maybe even the frequency of the exercises. You try to, provoke that response, provoke that stimulus to get them a little sore, so that you're building capacity in those tissues. So those are just kind of two common examples of the way we can figure out whether we're dosing and then titrate what we need. I think this is an ongoing process. We probably need a lot more information about how we're going to dose folks. When it comes to joint injury, we really have to respect how the joint responds. And so sometimes joint pain or joint swelling, those are two things that we have to pay attention to quite a bit, especially after things like cartilage procedures or other surgical procedures where a lot of recurrent swelling would not be something that we want to introduce. So it's like balancing all these scales and trying to make decisions about, which dial to turn and when and how much.
I am so glad that we're recording this, because that was an absolute masterclass on dosing. It was awesome. So, what role do you see your research playing in other physical therapy disciplines? And do you see any overlap?
My work is pretty small in orthopedics and sports medicine, but if you were asking me about like our particular methods, I do think what I'm excited about too for PhD students and early career researchers coming up is we aren't as married as we used to be to clinical conditions of interest. When I started training, I was really interested in hip and knee injuries, and that's, if you look at my publications, that's really where I started. But over the course of my career, I've developed really what I would consider as skills of a methodologist or a trialist, and maybe a true biomechanist if I dare, where someone can come to me and say, "Hey, I've got a rehab trial for stroke survivors or chronic brain injury survivors," which is an example of something I'm doing now, or upper extremity, hand problems, whatever the case may be, and I can approach it from a design perspective and with a trialist mindset. Same thing with biomechanics. If there's a human movement problem, a biomechanist should be able to help you, and physical therapists have that like early understanding of movement. Biomechanics just takes it to a new level by really helping us understand how to quantify it, how to interpret that, how to process the data, and how to interpret it. So that's, I think, maybe where my work or our collective work can have influence on other disciplines or other practice settings, is we really understand how to measure human movement, how to interpret that data, and then how to apply that broadly.
It kind of brings us to the bigger question, is the wider impact of your work and how you communicate its value. So what challenges have you faced communicating the value of PT research beyond academia?
Yes, I would say that this is not my area of strength, and this is my commitment going forward, and maybe a product of the fact that I am now working with implementation scientists who are helping me understand, how to bring this to a real world, and then, how to communicate it going forward, how to bring it to policymakers, how to bring it into the classroom, how to bring it to the clinic. So I think things like what you guys are doing now, which is trying to get folks to share their expertise in a medium like social media or podcasts or similar, and trying to simplify the information, not dumb it down, just simplify it and make it practical for the everyday user, whether that's the patient or the clinician or other multidisciplinary collaborators. I think it's really important for our ability to just make sure we're communicating exactly what we found in a way that really makes sense to the end user. So for patients, our language might be a little bit different than our language with clinicians. I think we can get to a place where we can use perhaps social media as a primary medium to make that connection, because we're used to living in the lab, we're used to writing manuscripts, we're used to sharing this information at national conferences. We haven't been quite as good at being closer to the community and closer to the people that are truly going to use the information and benefit from the information.
Kind of on that topic, when you talk about kind of sharing some of these stories, if you will, I know you mentioned that obviously you have kind of a set of stories that you discuss, with your peers in research, but you also mentioned maybe some stories that you would share with the patient. I'm not a PT, and I would kind of like to hear, if you wouldn't mind, kind of what you would tell a patient, like what kind of stories that, to help me kind of better understand everything that you're doing.
Yeah. So let's take maybe the dosing as a good example. A lot of rehabilitation studies are comparing maybe different dosages of things, or dosages of interventions, or slightly different interventions that we think could be the great active ingredients, the change makers, right, in somebody's recovery. So if I'm explaining this to a patient, if they were to ask me about my research, which sometimes they do, the conversation would be something like, look, here's what we know about knee pain, or here's what we know about hip pain. Here's the treatment approaches that we currently have. Right now, we only have treatment A and treatment B, and the outcomes of those treatments are kind of mixed, and we don't really understand for whom and when that treatment is best. So then I would bring it, to kind of our conversation. Our particular group, we're really trying to figure out for whom it's best, and so to do that, we're grabbing everybody who has this clinical problem, but people who are a little older, people who are a little younger, people who have different, this person has a little more weakness than this person has some different range of motion. We're trying to collect a really different and widespread representation of the clinical condition. We're going to give everybody this one particular intervention, or maybe this intervention and that intervention, and then we're going to follow them. We're going to watch the natural progression that occurs under these special conditions. And we're going to measure strength and we're going to measure, how you feel about your hip function or your knee function. We're going to measure things that matter to you. And so in helping them understand why we choose to test certain treatments, those active ingredients, how we measure the effect, these aren't uninformed people. Our patients are smart. They know how to consume information just like we do. And so I think if we have the time and sort of crack that door and let them peek behind the curtain a little bit, it's a lot easier for them to jump on board with us and say, okay, I understand why you're exercising me till I have discomfort. I understand why we're applying this test. You're trying to understand if this treatment works. That's all part of the investment and developing that alliance that patients have with clinicians.
Totally makes sense. Thank you for that. So to kind of tie up everything, I want to kind of spend some time talking about the future of PT research. And one thing I've learned more recently, being a part of the board, is that these research projects can take quite a number of years. And I know that we already talked about technology, but there's been a lot of changes with technology in the last, 5-10 years. I mean, every day almost. So with all these advancements in technology, I'm kind of curious, how do you see technology shaping new areas like Alzheimer's disease and pelvic pain?
Yes. So I think what I am continuing to learn is the potential impact of physical therapy on diseases and health conditions that we never really considered under the umbrella of physical therapy. And that's probably different than students view it now, because they're exposed to all of these things. And that's not that's not the space I came from 20 years ago. I don't think we really thought about the potential impact that we have and the way we can study these disease mechanisms. I review grants for early career investigators for the National Institutes of Health, and so this is my perspective on that experience. I've seen a lot of grants come through looking at Alzheimer's disease and related dementias, and the fascinating thing I'm finding is how they are trying to understand how movement and those health conditions are tied together, and how changes in movement might be signatures of disease process and disease severity. And that blew me away. That is not my area of expertise. That's not something I have been trained to study. But I just thought, again, 20 years ago or so, Alzheimer's disease was a problem that then physical therapists tried to help people cope with. Now, maybe we can help identify and collaborate in a multidisciplinary way earlier to slow that disease progression. I never thought that was possible before. So those are some of the things I'm excited to see coming forward. Pelvic pain and areas of women's health, I think, we just started to crack that area open, and there are so many functional anatomy relationships between spine and pelvis and hip and pelvis. I think we'll just study these things in a completely different way with a completely new perspective. And again, leaning into those multidisciplinary teams when we have those conversations around the table, in sharing those ideas, what have you seen, Dr. So-and-so, like athletic trainer, what have you seen? What is a women's health specialist, a doula? What have all of these practitioners seen? Bringing those experiences to the table with the patient perspective, then we can start to unpack, wait a minute, there might be something here that we can study together. And so I think that's potentially the next avenue. The next step forward is continuing these multidisciplinary collaborations, leaning into developing technologies, and being bold enough to ask questions that we haven't asked before.
I love it. And talking about, questions that we haven't asked before, I'd like to kind of pick your brain on maybe some technology that is on your radar that is maybe not necessarily mainstream. Do you have your eye on anything?
Oh my goodness. Well, I'm probably not the best person to ask about all of these things, because there are many other people who are really at the forefront of that work and that are co-developing, these technologies with, all the incredible and relevant stakeholders in that process. What I'm really excited for is platform and app-based and wearable technology supporting our ability to interact with a patient in their environment. At Ohio State, we're lucky. We're in a metropolitan area. We have clinics set up sort of around the larger area to provide additional access to our patients. But there are still a lot of patients that we don't reach, who can't get to a clinic regularly, maybe who don't want to get to a clinic regularly, or for other reasons. And so if we can engage them with that type of technology and give them the same level of care that we would in the clinic, man, I think that's really an opportunity for us. I mean, the whole goal is to make sure that people have exactly what they need and when they need it. And I am really excited about what the future holds in that regard.
Now, before I let you go, I do have one final question.
Okay.
So there is probably going to be somebody out there watching this video who is interested in pursuing a career in research. Could you leave them one piece of advice?
Oh my goodness, one piece of advice. I say
Two pieces.
ask the big questions. Don't be afraid of wanting to tackle a big health problem. If you think that your expertise or your desire to change outcomes for people with osteoarthritis is a thing that you're passionate about, we need you. We need lots of brains on these problems. And we need people with different perspectives, and we need people who are willing to stick their neck out and maybe say something or offer an idea that hasn't been offered before. I think those conversations really breed innovation. That's where the rubber meets the road. We have to have people willing to say, like, have we thought about it this way? Or what about this? Or have we ever tried this particular, method? Those innovative ideas, that's what's going to push things forward and really deliver quality care for our patients. So go for it, ask good questions, don't be afraid, put yourself out there, and then find, if you're in a PT program, find a professor you can talk with who might have experience in the area, who can offer some suggestions about how you might take that path, because it is long, it does take some strategy, and but there's a network of people out there that want to embrace new people to the profession and like I said, support their research mission.
Awesome. I cannot tell you how appreciative we are for your time and your expertise on this matter today. I hope that everybody takes a lot back into the real world as we look forward to the future of physical therapy. So thank you so much again.
Yeah, thank you so much for having me, Dave.